Good afternoon and welcome. And thank you for joining us today. Sorry about the slight late start, technical difficulties, but we're on top of it all now. While everybody logs on, and we'll give you a few minutes to get settled, we'd like to make you aware of the chat function that is down the bottom. If you can just jump on that, say hi, let us know where you're joining us from. We'd love to hear from you. My name is Leah Pett, and I'm the Webinar and Health Professional Engagement Coordinator here at the Stroke Foundation. And I'm very pleased that you could be joining us today for what promises to be a very informative and interesting webinar. Today's webinar is on identifying and understanding childhood stroke. We're joined today by our presenter, Associate Professor Mark MacKay. Mark is the paediatric neurologist and director of the neurology department at the Royal Children's Hospital in Melbourne. Mark is recognised both nationally and internationally for his contribution to childhood stroke clinical care and research. His interest areas include understanding the causes and consequences of perinatal and childhood stroke and increasing access to treatments to save viable brain. Warmest welcome, Mark.
Thanks very much, Leah.
Thanks. Also joining Mark today is Belinda Stojanovski, the National Coordinator for the PAC study. Very important. Hi, Belinda.
Hi, Leah. Thanks for having me.
Thank you. And joining us from the Stroke Foundation is our very own Childhood Stroke Coordinator, Marty Greenham. Marty will be moderating any of the questions you have for Mark and Belinda at the end of the presentation. Hi and welcome, Marty.
Thanks, Leah.
Acknowledgement of country. Stroke Foundation respectfully acknowledges the traditional owners and custodians of country throughout Australia and acknowledges their continuing connection to land, water, sky, and community. We pay our respect to the peoples, culture, and elders, both past and present, for they hold the memories, the culture, and the hope for their peoples. I would like to acknowledge that I am joining you today from the lands of the Turrbal people here in Meanjin, Brisbane. Quick spot of housekeeping before we get started. Please jump on and use the Q&A function at the bottom of your screen to submit any questions as they occur to you throughout the presentation, and we'll be sure to ask Mark and Belinda to answer them at the end of the session. If you see a question that someone else has asked that you also want answered, you can click the thumbs up button under the question and that helps prioritise it for us. With housekeeping out of the way, let's get started. Handing over to you, Associate Professor Mark MacKay, and thanks, Mark.
Thanks, Leah, for the opportunity to speak today. I hope that you'll find the presentation interesting, and I look forward to questions at the end of the presentation. So this is the learning objectives from today's session. I'll start by briefly discussing stroke incidence in the paediatric population, which includes newborns and children. I'll discuss the key differences between children and adults. I'll then move on to the modes of presentation which differ between newborns and older children. And then most of the talk will be focused on the challenges to rapid stroke diagnosis in children. I'll touch briefly on reperfusion therapies in children, and then secondary prevention, and focusing on the conditions which are associated with stroke. And then move on in the last part of the talk to what we consider to be important priorities and recent research initiatives which are addressing some of those priorities. And these include the Paediatric Acute Code Stroke Study, also known as PACS, and the NIMBUS study, which is a neonatal stroke study. And then I'll spend a little bit of time just talking about Perinatal Stroke Guideline Project, which is still in development. Okay, so this is just some quick facts on childhood stroke. That arterial ischemic stroke has an incidence of, depending on the study that you read from around the world, incidence of between 0.2 to 7.9 children per 100,000 children per year. In contrast to adults, where hemorrhagic stroke only accounts for maybe 1/4 of strokes, hemorrhagic strokes is almost as common and has an incidence of 0.7 to 5.1 100,000 children per year. As far as the spread across the paediatric age spectrum, 1/4 of paediatric patients with stroke are newborns, 1/3 are less than 1, and half are less than 5 years of age. And based on mortality data from the US, stroke is amongst the top 10 causes of death in children. Stroke has a 10 to 20% recurrence rate, and more than half of children who are affected by stroke have long-term neurological impairment. So there's two important aspects to that. The first is that there's really an impetus to improve recognition of stroke, to minimise brain injury, and also to have a coordinated approach to rehabilitation of children on their journey to recovery. The key differences to adults are that the majority of children are well prior to their first presentation. So children do not have conventional atherosclerotic risk factors. In the remaining children who are not well, the risk factors are different to adults, and I'll touch on that in the section of the talk where I address secondary prevention. Arteriopathic stroke in children is not atherosclerosis. It's due to genetic or inflammatory processes affecting the arteries. There are higher rates of stroke mimics in children, and the spectrum of those mimics differ from adults. Limited evidence for reperfusion therapies does not mean that children cannot access these treatments, but we need to have a coordinated approach to care. And because children do not recover better than adults, missing those early treatment opportunities to minimise extended brain injury means that we're potentially sentencing children affected by stroke, given that more than half occur under the age of 5, to potentially decades of living with disability. So now I'll move on to the acute management of childhood stroke. And there are a number of challenges to improving stroke care in children. The first is that stroke, as I've already demonstrated based on the epidemiology, is an uncommon event. So that would be estimated to be 1 in 62,500 children per year. And therefore, it's not on parents or ED physicians' radar. So parents usually identify if their child has symptoms relevant for stroke, that there's something seriously wrong, but they don't necessarily consider stroke as being a possible cause. 75% of children will have a mimic, and migraine is the most common mimic in children. The etiologies, the causes of large vessel arterial occlusion in children are more varied than adults, with causes including things such as congenital heart disease, cervical arterial dissection, or inflammatory arteriopathies. And as a result, there's a lack of evidence for both acute therapies, reperfusion therapies, but also for secondary prevention. The other issue is that there's good data to demonstrate the risk-benefit ratio of reperfusion therapies, and so TPA within 4.5 hours, clot retrieval within 24 hours, but there's very limited data on the characteristics of the ischemic penumbra, which is a target for reperfusion therapies in children. So this is a slide that I put up because when I've given this presentation to my adult neurology colleagues, there are a number of ways that you may, if you're an acute care clinician, that you may encounter a child with stroke. The first is that teenagers, particularly with stroke, may arrive by ambulance to a comprehensive adult stroke centre. They may be brought there directly by ambulance. Children and teenagers may arrive to a metropolitan centre that might have a paediatric department or a regional hospital, and so that is not uncommon in our experience. And we know that about half of children with stroke will not present, or they'll present to a non-tertiary centre. And then the other potential encounter would be that you may receive a call from a general paediatrician in a regional metropolitan centre, or even a paediatric neurologist requesting advice following diagnosis, because stroke is an uncommon event. Now, stroke, the key point, this is sort of probably key point number 1 as far as how stroke presents in children. Essentially, it presents in the same way with adults with focal deficits. So the FAST acronym is very relevant to the paediatric population. The only exception is that seizures, which in adults are predictive of a mimic diagnosis, are quite frequent, a quite frequent symptom. And so the literature suggests that maybe around 1/4 of children with stroke will present with seizures in addition to other deficits. But I think we've done some work in our hospital. This was the focus of my PhD, and we did show that in stroke that the predictors of stroke are sudden onset of symptoms, and then motor deficits, weakness in ability to walk, speech deficits, dysarthria, dysphasia, and altered consciousness are predictive of stroke. whereas mimics, gradual onset of symptoms and non-motor symptoms are more predictive of a mimic diagnosis. So migraine is the most common mimic in children presenting with focal deficits. Approximately 1/3 of those children will have a migraine as the diagnosis. And if we, the reasons why they present with visual and sensory symptoms is because of this concept of spreading cortical depression, where when you have migraine, you may initially have some positive symptoms, which may be shimmering lights, which are then followed by scotometer. And that is this concept of Leo's cortical spreading depression, where you get an initial wave of excitation. So you get positive symptoms. So that may be visual symptoms, if it's because it always starts in the occipital cortex and then it spreads forward from there into sensory cortex and rarely into motor cortex or language cortex. So I think the key point is if a child presents to hospital and they still have focal deficits, well, then it's likely to be a stroke. Whereas migraine, as people in the audience who may suffer migraine know that if you do get those visual symptoms, they're typically transient, lasting half an hour, maybe an hour maximum. So by the time that child, if a child has a migraine, by the time they have arrived at hospital, those focal neurological symptoms have typically resolved and then have been replaced by a headache. So when the child presents to the ED, there's really, and you're considering imaging, there's really 3 questions that need to be answered in order to consider reperfusion therapies if you suspect ischemic stroke. The first is, can you see radiological evidence of ischemia, so infarction, acute infarction? Is there a hemorrhage, which would be a contraindication to use of thrombolytic agents? And then thirdly, is there a vessel abnormality, which might be a target for endovascular clot retrieval? So CT imaging is a standard acute imaging modality in adults, but we know in children, and this would be the standard investigation that would be performed, but we know that non-contrast imaging has poor sensitivity for detection of acute ischemia in children, based on several retrospective studies, including from our centre. And therefore, if you are going to do a CT, then CTA is essential if you're using a CT-based imaging protocol in the emergency department. Now, CT versus MR to diagnose stroke, CT imaging may be adequate to make decisions about the appropriateness of reperfusion therapies in children. This is based on a very good study from my colleagues at Sydney Children's Hospital and from Westmead Children's Hospital, where they looked at statewide data, where they found that you could actually make decisions on CT quite adequately. But one of the key concerns about CT is radiation exposure in children and the increased cumulative lifelong risk of malignancy. And therefore, MRI is considered to be the diagnostic imaging modality of choice if it's available. But the reality is that for most centres, MRI is not available in the ED. Now, it's just an example of a code stroke protocol that's been developed at the hospital that I work at, the Royal Children's Hospital in Melbourne. And just to focus on the imaging, so the code stroke is activated in the ED, child is urgently assessed by the neurology team. There's discussions with the radiologist that whether the child needs a scan. And then we have 2 options here. One, which would be our investigation of first choice, would be to do a rapid MRI, which I'll talk about in a minute. But if that's not possible, then rapid CT imaging is performed. And at our institution, we have a non-contrast CT angiography. So is there a vessel abnormality, and then CT perfusion, is there salvageable brain? And then from there, then the decision making is based on whether there is hemorrhage or suspicion of ischemic stroke. Now, this is just to demonstrate, this is a rapid MR protocol where you can just do a limited number of sequences, which are listed here. And this protocol, you can acquire the information that you require to answer those 3 key questions. Is there ischemia on diffusion imaging? Is there a bleed on susceptibility weighted imaging? And is there a vessel abnormality on the MRA? This information can be acquired in 7 to 8 minutes if you have these predefined protocols. Now, the way of the future is that perfusion imaging will likely play an important role in selection of children for reperfusion therapies, because now in adult stroke, there has been a move towards imaging-based selection of patients in extended time windows for clot retrieval using CT perfusion imaging, but we don't have data at the moment, so it may not be appropriate to extrapolate data from adults for a number of reasons. Firstly, cerebral blood flow does vary by age, and that cerebral blood flow increases progressively up to age 9, and that's where up to age 9, and then it will drop a little bit beyond age 9. So there are age-related changes in cerebral blood flow. There are alterations in baseline perfusion characteristics are seen in conditions which are strongly associated with stroke, such as congenital heart disease. And there's also limited data on collateral characteristics in children. There is one recent study from Stanford by Sarah Lee and colleagues, which was published a couple of years ago, where they found that children do have favourable collateral profiles, and that those collateral profiles were associated with smaller final stroke burden. But when they looked at the outcome of the children, that was not associated with better outcomes, but that was probably because of the small numbers of patients in the study, which meant that it was underpowered to demonstrate this. So this is an example. We are using perfusion imaging, both MRI and CT-based perfusion imaging at our hospital. And this is an example of a child who presented. This child had a history of congenital heart disease, ventricular septal defect, and then a patent ductus arteriosus, who presented with sudden onset of left hemiparesis. And this MRI, rapid MRI, was performed 4 hours post-symptom onset. And this child on the diffusion imaging, this is the ADC map here, an axial image showing here in the right hemisphere on the left side of the image, there is a lenticular striate area of infarction, restricted diffusion. MR angiography here, you can see normal left middle cerebral artery here, but on the right, there's an abrupt cutoff. So this patient had a large vessel arterial occlusion. And this is a perfusion imaging which shows the core infarct, which had a volume of 15 mils, but there's a much larger area of hypoperfusion surrounding that. So this is the perfusion deficit. And so to determine the amount, the volume of salvageable brain, you subtract, this is using the rapid automated software, you subtract the diffusion core from the large of deficit, and then you have a volume of salvageable brain of 23 mils. And based on adult data, this would be considered a favourable profile, and this child proceeded to clot retrieval and had a good outcome. Now, the other difference between adults and children is that approximately half of childhood strokes occur in hospital, and that's because the cardiac disease is the commonest, one of the more common risk factors for stroke, and therefore we need co-stroke protocols which are tailored to the inpatient population, including children with heart disease. So this is another patient, another example of perfusion imaging of a 12-year-old boy who was from New South Wales, who was awaiting cardiac transplantation at our hospital, because the Royal Children's is the National Centre for Cardiac Transplantation in Children. And he had sudden onset of dense left hemiparesis and aphasia. And he was imaged at the Royal Melbourne Hospital, which is our adult stroke comprehensive centre, which we partner with. He was transferred there, where he underwent CT perfusion, which showed on the CT cerebral blood flow there was no core lesion, but he had a large area of hypoperfusion on the CT perfusion study, which was 79 mils. And this patient, and this imaging was done at 50 minutes post-symptom onset. And his CTA, I should say, showed that he had LVO. He actually had 3 vessel occlusions. The first was in the proximal part of the middle cerebral artery. So this is the right middle cerebral, that's the internal carotid here, right middle cerebral, the M1 branch, which then branches into 2. And you can see here where the arrow is, there's a filling defect. That's where the first clot was. So that was removed by clot retrieval. When that clot was removed, it was identified there was a second clot that was more distally in that vessel, which was removed. But then he had a third clot. This is a lateral projection of the carotid showing the middle cerebral here. And this is the anterior cerebral. And there was an abrupt cutoff here where we had a third clot in the A2 segment of the right ACA. So that was also removed. So I'd like to now move on. I've touched a bit on clot retrieval. So I'll just talk a little bit about reperfusion therapy. So they include TPA, and there's minimal data on TPA, and there is an international collaborative which is called the International Pediatric Stroke Study, of which our hospital is a member, and this collected data on 26 children aged up to 17 years who presented with stroke to report outcomes following treatment with TPA. And these children were treated within 4.5 hours, which is the recommended time window for TPA. And of those children that were treated, 2 children developed epistaxis, but none developed symptomatic intracranial hemorrhage, which is the most serious complication of treatment. And Bayesian modelling estimated that the risk of symptomatic intracranial hemorrhage was 2.1%, which is, I understand, lower than in adults. The interpretation of efficacy of TPA, however, was limited by incomplete clinical data because that was only available for 2/3 of children. So that's TPA. If we move on to clot retrieval, and this is really a landmark study, which is from the New South Wales group from the 2 major hospitals there, which has really received a lot of international interest because it's the first study of its kind where they actually took a population-based approach and they identified children within New South Wales over a 10-year period that were diagnosed with stroke. And of those, there were 166 cases with arterial ischemic stroke, and almost 1/4 of those had a large vessel occlusion. So the rates of LVO are similar to adults. The proportion of children who present with stroke who have a large vessel occlusion is similar to adults. So in these children, 1/3 of those children were treated with clot retrieval, and 2/3 were treated conservatively. And they found that when they looked at the outcomes, that children who were treated conservatively, i.e. did not access clot retrieval, they had 73% of those had poor neurological outcomes, and that was compared to 50% of those who did receive clot retrieval and 41% who did not have large vessel occlusion. So what this suggests that if you have a large vessel occlusion, that if you don't treat it, you will have poor outcomes. So I think that emphasises the need to develop access to these therapies. So so if we are going to improve outcomes, we need to standardise the approach to acute care. And the first step in that was development of national guidelines, which I was the chair of the guideline development, which happened over 3 years, and the guidelines were officially launched online in mid-2017. So this was really the starting point of recommendations around the management of stroke. And one of the key points is that children need to be considered within established metropolitan and regional systems of care. So there's no need to reinvent the wheel. So for example, in Melbourne, if you have a child who presents with a stroke and they're a teenager, the question is, at our hospital, should they come via road ambulance to the Royal Children's Hospital? We do not have on-site ECR facilities, so that would then mean that those children would need to be transferred to the Royal Melbourne Hospital, or could they actually be treated in the mobile stroke unit? So the systems of care vary from city to city, state to state, and so we need to have a tailored approach. So that has really led to the Australian Pediatric Code Stroke Study, which is an MRFF funded initiative, $4 million of funding, which was awarded to the Stroke Foundation in mid-2020 to develop a national approach to acute stroke management in children, to close the inequality gap between adults and children in accessing best practice acute stroke care. And so this is a partnership between the Stroke Foundation, the Murdoch Children's Research Institute, and all tertiary paediatric hospitals around the country, and also including Auckland in New Zealand. And they're also partnering with the adult comprehensive stroke centres that are associated with those paediatric centres. The primary aim of the PAC study is to increase the proportion of children aged 2 to 18 years with stroke diagnosed within 4.5 hours. And the secondary aim, and one of the most important secondary aims, is that we want to increase the proportion of children who are receiving reperfusion therapies. We also, pre-hospital care is obviously very important, so we want to improve the accuracy of paramedic diagnosis, but also of ED physician diagnosis by developing some tools that will assist ED physicians, and by developing those resources and tools, we want to demonstrate improvements in paramedic and ED physician practice, which will then mean that we've got shorter times to diagnosis, both transfer to hospital and also diagnosis in the ED. Importantly, we need to measure the economic impact of shorter time to diagnosis and increase rates of reperfusion therapies, which would then argue the need for ongoing coordination of care. Now, Belinda Stojanowski, who is on the panel, is the national coordinator for the PAC study, and she's provided me with some updates on progress, which I'll share with you shortly. But the study is a pre and post implementation study, so it's staged. It's two-tiered pre-post interventional study, which will be used. That's the methodology to evaluate PACs. So there are 3 tertiary hospitals, which include the Royal Children's Hospital in Melbourne, Monash Children's Hospital, Melbourne, Queensland Children's Hospital, who all have established co-stroke protocols, who will be testing a suite of adult interventions, which include pre-hospital pathways, protocols, automated perfusion imaging, clot retrieval protocols, and stroke telemedicine. And then the remaining 5 Australian centres and an additional New Zealand centre will be developing their protocols. So the study's been running for 18 months across all centres but one. And then once we've got baseline data, we will then measure the effect of those protocols on improving the access to treatments and shortening time to diagnosis. So this study is currently due to end, I think, Belinda can correct me here, but I think it's mid-2025. And so this is the progress, and these are Belinda's slides. So this is just to show you the sites. So there's Perth Children's Hospital, Queensland Children's Hospital, but also we're looking at developing that at Gold Coast, Newcastle, John Hunter Children's Hospital, the 2 Sydney Children's Randwick and Children's Hospital Westmead, Monash and Royal Children's in Melbourne, and then also Auckland. So these are the sites. And this is the progress that code stroke protocols have now been finalised at 4 of the centres. A further 3 centres in New South Wales have functional draft protocols, and Women's and Children's are well on the way with developing their protocol, and Perth Children's are yet to develop theirs, but are working through ethics. The intervention, so perfusion imaging, has been implemented at 2 hospitals in Melbourne, and Queensland are in the process of implementing the protocol at Queensland Children's Hospital. Decision support tools for ED physicians are being tested at 2 centres. State ambulance services, there are a number of initiatives in Victoria and Queensland. I'm not sure about other states, I think possibly New South Wales. And then telestroke, we've also commenced work on that with the Victorian telestroke service to develop or pilot telestroke protocols at 3 sites in Victoria. So this is just sort of to share our experience from our institution about how much this has transformed. The PAC study has already transformed care. So this is just to show that the code stroke activations, this is obviously quite a low number by adult standards, but with an average of 1.3 per month over this time period. And the importance of the neurologist going down to see the patient is that the code stroke, once the child was clinically assessed by the neurology team, the code stroke was stood down in 16% of patients. In the remaining 84% of patients, the decision was made to proceed with rapid imaging. And of those scans, the majority are performed either in hours or up to 10 p.m. On weekdays, and then there's about a third on weekends, but there's very few that occur after 10 p.m, which is important because doing an urgent scan after 10 p.m. has significant implications for workflow for the medical imaging departments. And this is one of the concerns that's been raised by our imaging colleagues. Now, of these patients at our hospital we proceeded with imaging, over a third of those had confirmed stroke, of which the majority were ischemic stroke. So we had 15 patients with ischemic stroke. And of those patients, more than half received reperfusion therapies, which 2 received TPA, 5 clot retrieval, and then 1 patient had both TPA and clot retrieval. So this is a huge change in our hospital, and when you benchmark that against international data, it's about approximately 2% of children with stroke access reperfusion therapies based on US data. So this is really transformative, this work. So just to summarise this component of the talk, sudden onset of focal deficits in a child, this is for acute stroke care, I should say. Sudden onset of focal deficits in a child is a stroke until proven otherwise. So if you have a child who has those deficits, you should activate a stroke. So in other words, no different from adults. MRI is the most sensitive imaging modality for detection of ischemic stroke, but CT with CTA is appropriate for the majority of centres around the country where MRI is not available. Fusion imaging may be the way of the future, but more data is needed in children. Limited evidence suggests that thrombolysis is safe in children, but we need more data with regard to efficacy. Clot retrieval is technically feasible in young children, but its safety and efficacy need to be determined. And that's where the PAC study, that's why it's so critical. And the PAC study will transform acute care of children with stroke and provide evidence in support of reorganising paediatric systems of care, which are aligned with adult systems of care. So now I'd just like to briefly touch on secondary prevention of stroke. And there are significant limitations of the paediatric literature. The first is that etiology is the most important determinant of secondary preventative treatment and recurrence risk in children. And I'll elaborate on that in a minute. But cardiac stroke and moi-moi disease are the 2 conditions in children which have the highest recurrent rates, with moi-moi approaching 25 to 30%. The evidence base for adults for antithrombotic treatment is based on data from tens of thousands of adults, whereas for children it's based on tens to hundreds. And therefore, our approach is currently that antithrombotic treatment recommendations are largely extrapolated from data arising from adult trials. So there are 3 international guidelines I've already mentioned, the Australian guideline, but in the same year, the United Kingdom published national childhood stroke guidelines, and then the American Heart Association, American Stroke Association published guidelines in 2019. And these vary. So when it comes to antithrombotic treatment, the UK guideline recommends case-by-case decision-making. So even for patients with cardioembolism, they would not necessarily anticoagulate those, whereas the Australian guidelines recommend anticoagulation for cardioembolism and dissection, and the American Heart Association guidelines recommend anticoagulation for cardioembolism, congenital thrombophilias, and prior thrombosis, but they do not make specific recommendations for extracranial dissection. So that's antithrombotic treatment. There's not really consensus. And then if you look at the conditions underlying stroke, then I think these are the key areas where I think there's controversy, which may be of relevance to adults where if you're asked for advice. So the 2 key randomized trials in adults do not support superiority of anticoagulation over antiplatelet therapy. So I think that potentially the Australian guidelines may need to be reviewed in that regard. Patent foramen ovale, which is a cause for cryptogenic stroke in young adults, the evidence supports percutaneous endoscopic closure, and therefore, based on that data in young adults, we extrapolate that to children and generally do recommend closure of PFOs in the absence of an other identifiable cause for the stroke. Right, my light's gone off because I'm not moving. Just give me a sec. So moi-moi disease, meta-analysis. So moi-moi disease is a progressive arteriopathy. Meta-analysis supports direct or combined bypass procedures over indirect procedures in adults. So that's literally where you hook up the middle meningeal or superficial temporal artery to the middle cerebral. But in children, because the vessels are smaller, indirect procedures are generally recommended. I don't have time to go into these today. And then finally, focal cerebral arteriopathy, which is an inflammatory problem which often follows viral infections such as varicella, which is the cause of chickenpox. Adjunctive corticosteroid therapy is an area of active research, and there are 2 international trials that are currently investigating it. So now I'll move on just to, in the last 10 minutes, I'll move on to perinatal stroke and just talk a little bit about that. So I'll start with just talking about perinatal stroke refers to a stroke event occurring up to 1 month post-birth, but it can present in different ways. So it can firstly present symptomatically in a baby on the neonatal intensive care unit or on the postnatal ward with a seizure, and that can be due to an ischemic stroke, which is shown here. This is an axial diffusion MRI showing an area of MCA infarction. It can be due to sinus venous thrombosis, which can occur in infants with other problems, but where they may be dehydrated. And then thirdly, by a neonatal hemorrhage, which can be due to a variety of underlying causes. Importantly, perinatal stroke can also present as a delayed phenomenon where the parents notice that the child has an early hand preference. So those of you who have children would know that children do not declare themselves as being left or right handed typically until about 18 months of age. So if a child at age 6 months is very strongly favouring one hand and reaching for toys, crossing the midline to grab toys with one hand, it means there's a problem with the hand that they're on the side where the toy is. That indicates that there is a problem. And in those children where they have an early hand preference, that can be an indicator of cerebral palsy. And stroke is the most common cause of cerebral palsy in term infants. So a child with an early hand preference would undergo an MRI, and you may find a large area of infarction, and this radiological pattern may indicate stroke at the time, around the time of birth. But there are other forms that occur earlier in utero where you have injury to the periventricular white matter, and that's called periventricular venous infarction. So these are the quick facts on perinatal stroke. The incidence of symptomatic stroke is much higher than in older children, so 1 in 2,500 babies per year. So that's 5 times higher than older children, and it's equivalent incidence to stroke in young adults. And based on birth data from Australia, this would mean that approximately 120 Australian babies suffer a stroke each year. And the vast majority of these children present with seizures. I'll explain why that is the case in a minute, why they don't present with hemiparesis like an adult or an older child. The disease mechanisms are poorly understood. Babies do not recover well, and almost 50% experience permanent neurodevelopmental problems. And as I mentioned before, stroke is the most common cause of hemiplegic cerebral palsy. So many people have heard of cerebral palsy, but what they don't know is that stroke is the most common cause in babies that are born at full term. So I'd just like to talk about the perinatal guidelines, which are being led by my colleague, Dr. Sarah Kerno, who's a paediatric neurologist at our hospital, and she is leading the development of statewide perinatal guidelines. Now, these are the key questions that we are asking, which we are reviewing the evidence to provide recommendations for each of these important questions. The first question is, what risk factors are associated with increased risk of stroke? What clinical symptoms on the postnatal ward or in the NICU warrant consideration of urgent brain imaging to diagnose perinatal stroke? Which imaging modality, so that could be cranial ultrasound, CT, MRI, which imaging modality and which protocol most accurately diagnoses perinatal stroke? And then once you've confirmed that there is a stroke on your imaging, do investigations for underlying causes, influence management, prognosis, outcome, or counselling. And then finally, is there a role for antithrombotic treatment to improve functional outcome, reduce recurrence risk and mortality? Because we know that perinatal stroke has a very low recurrence risk. So this is to give you an example of the challenge that we face with regard to early intervention in children, that although neurodevelopmental impairments occur in 2/3 of newborns and roughly 1/3 develop cerebral palsy, those problems are not evident in the newborn period, and I'll explain why that is in a minute. So the problem is that the way neurologists approach things is there's an injury to this part of the brain. That part of the brain subserves a particular function, that might be movement. So therefore, injury here means that child is going to have motor deficits, but it's not that simple. And this image here is to show that these are babies who have hemiplegic cerebral palsy, and these are their MRIs showing acute injury, acute swelling, the restricted diffusion, the brightness that you can see. And you can see that all those children have cerebral palsy, but the pattern of abnormality on their brain is different. Second issue is that you have some children who have exactly the same scan, same distribution of injury, this baby has cerebral palsy and this baby does not. So shown here and so on. So that's really challenging. That how do you counsel parents using standard imaging to guide them on what's the future hold for them and for their baby? Now, just to go back to why babies present with seizures. They don't present with hemiparesis. And there's a very good reason for that. And this study, which is over 20 years old, very nicely demonstrated using transcranial magnetic stimulation about control of function. So in babies, the key thing is that right hand function, you have bilateral control of movement. So both hemispheres are providing control of movement of the right hand. This is shown here where these thresholds, the dotted line indicates that they measure muscle activity when they stimulate the cortex. So they stimulate the left cortex, and this is the right hand, and this unbroken line is the left hand. And what you can see is that the ipsilateral, meaning that in this case, if we're talking about the right hand, the right cerebral cortex, you have earlier activation of that, but they're very similar. So both hemispheres are controlling movement. By 3 months, now you're seeing that the contralateral, so what you would expect in an adult, that the left hemisphere controls right hand movement, that is a bit earlier. And then over time, what happens is the brain just shuts down the ipsilateral control. So if we're talking about right hand movement, the brain just shuts down the projections from the right side of the brain to the right hand just get progressively shut down. And by 24 months, you've got very little activation of the ipsilateral cortex. And now almost all of the control is provided by the contralateral cortex, which is the standard arrangement in adults. So that's why babies don't have seizure, because if they have a stroke effect in the left hemisphere, the right hemisphere is able to provide input to the right hand. So they move their right hand normally. It also explains why babies who have cerebral palsy, that they don't show signs of that until they're much older. Now, this is all about maladaptive plasticity, and what the feeling is, and this is the key target for early intervention, is that the feeling is that hemiparesis, cerebral palsy following stroke in newborns, is due to excessive control of the affected extremity. So this side of the brain's been injured. You have communication between the two hemispheres across the corpus callosum. You have projections from both sides. And so it's the abnormal, sustained, preserved projections from the non-lesion hemisphere to the hand. If you transfer function from the lesion hemisphere to the unlesioned hemisphere, it seems counterintuitive, but that is associated with poorer prognosis. And this is sort of demonstrated here, where they show, again, TMS in the same study, an adult, where they stimulate the brain, they get activation of the contralateral hand muscles, but nothing much on the ipsilateral side. In stroke, in an adult, you don't get transfer of function. So this patient, there's a reduced activation of the contralateral hand from that stimulation, whereas in cerebral palsy, both hemispheres are contributing. So I think this is very interesting. So now moving on to what's the clinical management. So the standard approach to management of babies with stroke is that the occupational therapists and physiotherapists will do an assessment called general movements assessment, which is typically done at 3 months of age, where they're looking for early signs of cerebral palsy. And those of you who have babies don't know, a little baby under 6 months, they just wiggle around, they're just moving around, they're wiggling their fingers, wiggling their hands. So they're looking for asymmetries, that one's wiggling and the other's not. So it's a way of detecting abnormal signs. And the two patterns that reliably predict later development of cerebral palsy is persistent pattern of cramped, synchronized general movement. So that's the big movements of the arm, that it's not fluid, and then absence of the fidgety movements, which are the little finger wiggly movements. So an occupational therapist and a physiotherapist who has been trained can detect cerebral palsy at 3 months. But I think one of the key questions when I see babies in stroke clinics, the parents ask me, the common questions they ask are, why did my baby have a stroke? Is it something that I did or didn't do? How's the stroke going to affect my child's development? Could my baby have another stroke? And if I have another baby and I have another pregnancy, could my next baby also have a stroke? They're the questions that the parents ask, and it's very important to address those questions in the clinic when you see the families. So because these are important questions, we actually have now got funding from the National Health and Medical Research Council to conduct a study where we want to develop, we want to understand what are the mechanisms of stroke, what are the risk factors for stroke, and using proteomics, where you look at the pattern of different proteins in the blood, which can be shown to identify the causal pathways of stroke. So that's called a blood proteome, where you're trying to identify particular patterns of, these are all the different proteins, and looking at ones that are associated with stroke. So that involves the blood prick, putting on this little device, and then doing some analysis in the lab. So this study will take 50 healthy newborn controls, 50 newborns with stroke, and then compare the blood patterns for those babies. And the second thing that we're doing is we're looking at the connectivity in the brain. So what I explained before is that having a stroke, it's not just about where the lesion is, it's what that lesion, that stroke lesion, is connected to in other parts of the brain. So it's thinking of the brain as a connected grid, and that a lesion injury somewhere will affect those connections to other parts of the brain. So there is a database of normal babies' brains, which is called the Connectome, which was 500 babies which were scanned in the United Kingdom, and that information, we can use that information to look at brain connectivity. So that's what we're about to commence. So the key, I think this might be my last slide, the key practice points in babies with stroke is that if a baby presents with a seizure, you need to think about a stroke. And that's particularly the case for babies who have a complicated delivery, where there may have been abnormal heart rate during the labour, the need for assisted delivery, so that could be forceps or caesarean, having a low APGAR score at birth, or they need to be resuscitated. MRI imaging, based on the work that we've done thus far in the guidelines with diffusion imaging and these other sequences, is the investigation of choice. So if you have a baby where you suspect stroke, don't do a cranial ultrasound. MRI is the best test. Acute management of babies with stroke is involving the symptoms, or treating the symptoms, which is essentially seizures, and we don't typically use antithrombotic treatments because the risk of stroke is recurrent stroke is very low. But we would typically do an EEG because seizures that you can't see are not uncommon, and echocardiogram is also good to make sure there's not a heart abnormality. Okay, so just finally, I might even leave this slide up. This is a range of resources, all of which, bar one, have been developed by the Stroke Foundation. So, for me, it's been a privilege to work with the Stroke Foundation and to see the progress that the Stroke Foundation have made with input from parents such as Dee Banks, whose child had a stroke, and working in partnership with families, with hospitals, to develop resources which help families on their journey from onset to stroke recovery. So this is a booklet which is developed by the Stroke Foundation, provided to parents at the time of diagnosis, information for other children to understand that maybe that their siblings had a stroke, to give them developmentally appropriate information, warning signs of stroke, there's stroke line. So all these resources are out there now. This is really, compared to 20 years ago when I started out in stroke, it's really transforming our care. So I'd just like to thank the Stroke Foundation for their work and for the opportunity to speak to you today. Thank you.
Mark, thank you so much. I think everyone will agree that's been a fascinating presentation. I've learned so much, and all of the resources that Mark's just pointed out, we will have available for you post-webinar. But I am going to hand over just quickly. We have 10 minutes left. We've had a few questions that came through in the registration. Thank you to everyone who popped your questions in as you registered for the webinar. Marty, would you like to lead the Q&A with Mark and run through the webinar questions?
Thanks, Leah, and thanks, Mark. That was a really informative presentation. So we do have a couple of questions. Someone has asked...
do you know how to stop sharing? I'm having a bit of trouble. Can you take control now? And stop? Yeah. Sorry, just get my email. Yeah, that's good. Thanks.
Everybody's up.
Sorry,
Marty.
Mark.
No, thank you.
That's okay. Thanks, Mark. So somebody's asked, given that I'm more likely to see stroke mimics than a stroke in my regional centre, how do I balance the urgency of referral?
Yeah, so I suppose that if they could be a general pediatrician or an ED physician. I'm not sure the person who asked that, but I mean, I think one of the key points I would make is if the child comes to your centre and they have focal deficits that looks like a stroke, well then I would be, if you have an adult stroke service in your hospital, I would be seeking advice from those adult stroke neurologists, and I would also be seeking advice from the paediatric neurology team. So, for example, if it was in Victoria and the catchment area for Children's Hospital, would be calling the neurology team at the Children's. If you're in Gippsland, which is a catchment area for Monash, that you would be calling Monash Children's, and I think it would. So it's really making a decision. I think this child has a stroke. I think I need to get a scan. And if you're going to do a scan, most centres would be CT. You would do CT and CTA. But it's really working as a team, so that it would be someone organising those investigations, but also another member of the team on the phone to the adult stroke service and to the paediatric, the paediatric neurology unit that you're affiliated with.
Thanks, Mark. That's great. We've just had a question from Shani come through. What functional outcomes are used to measure functional outcome in the recent New South Wales study? What defines poor outcome?
So the NIMBUS study or the New South Wales study? Sorry, I think that they're referring to the clot retrieval. Yeah, so they use I think that was based on the modified Rankin scale. There is a paediatric equivalent to that called the Paediatric Stroke Outcome Measure, but it was based on the modified Rankin, which is a standardised measure that's been used for all the major stroke, thrombectomy and TPA trials. So same measure. Yeah.
Okay. And Ros Boyd has asked, Mark, very exciting to see your new program. Are you conducting any studies of early upper limb or gross motor intervention?
No, we're not. And people who don't know Ros is Professor of Physiotherapy in Queensland, who has done a lot of excellent research into cerebral palsy. So we're not at that point yet, Ros, where we're doing that. I think this study is really just to look at predictors of outcome, so that potentially we could identify that child is at high risk of cerebral palsy and other deficits at the time of diagnosis, and then we would then be implementing some of the interventions that you and your colleagues have developed, in the cerebral palsy randomized trial. So, I think we would definitely be wanting to draw on your expertise and the experience of the CP, research community on what they would be. In older children, I suppose something I didn't mention, but we are also in the process of developing some guidelines and consensus around the most important measures to assess outcomes, and that's a national initiative with buy-in from all the rehabilitation services around the country, and that's happening in parallel with the PAC study.
Great, thanks, Mark. We've had a question from someone else. What are the genetic risk factors for AVM malformation? Formation.
Yeah, so AVMs, there are some conditions that are associated with AVMs. There are some genes that are identified, and then there are also what we would call neurocutaneous syndrome. So there's capillary malformation AVM syndrome. So there are some conditions where you may have sort of indicators. So they have cutaneous skin abnormalities, and there are guidelines around screening those children to identify AVMs. And then children who have AVMs, hereditary hemorrhagic telangiectasia is a condition that can be associated with AVM. So I think at the moment, most of the research has been focused on ischemic stroke, and that's internationally, but there is now an initiative within the International Pediatric Stroke Study to start to pivot the focus to include hemorrhagic stroke. And I think that would be one of the key areas is identification of genes that are associated with both ischemic and hemorrhagic stroke, so that those patients are identified before they actually have a stroke. Or if they have a stroke, identifying genes so then the families can have appropriate counselling and the other family members can be screened.
Thanks. And Alicia, sorry, hopefully I pronounced your name right, has asked, are outcomes likely to be worse for perinatal stroke if both hemispheres are affected?
Yeah, so that's an interesting question because it's actually a rare occurrence, but I don't actually think I know the answer to that. You would say intuitively that they would be worse, but I actually have had patients with bilateral strokes where they've actually had good outcomes, and I think it's all to do with the maladaptive or developmental plasticity, what's actually happening at the brain at a reorganization level. So, bad outcome, meaning development of CP is associated with transfer of control to the unaffected hemisphere. So if you've got both hemispheres that are affected, does that mean that the brain is forced to maintain function in those two hemispheres? So I don't actually know the answer to that question, but I think that's where registries and collecting data, multi-center data, is really important so that we can actually determine that.
And another question from someone saying that you mentioned the guidelines, but is there a statewide registry for childhood stroke?
So as far as registries, I didn't actually have it in one of the aims of the PAC study, but actually one of the aims of the PAC study is to collect a national data set, a national pediatric stroke registry data set, and we're doing that in collaboration with the OSCA, and OSCA stands for the Australian Stroke Clinical Registry, which is an initiative that has been running for decades, which is led by Dominic Cadillac at Monash University. So we actually are, in patients who are recruited to the PAC study, their data is being entered into a national registry. That's for childhood stroke. At the moment, we don't have a statewide, I don't think there are statewide perinatal stroke registries. There are currently institutional registries. But in Victoria, I think that probably we're close to having a statewide registry, and the Nimbus study, I think, will facilitate that. I can't speak for New South Wales, but I know that Nadi Badawi and her colleagues are very active in the field of neonatal stroke and cerebral palsy.
Great, thanks, Mark. We've got a question about, are there currently any stem cell trials for children with stroke, and do you know the number of participants? So
there's not any that I'm aware of. There have been some animal studies looking at stem cells and showing that stem cells do migrate to the stroke area, and this is based on work from the US. I know that Nadia's group and Iona Novak, who's an occupational therapist in Sydney, who's an international leader, is very much leading that. There's not anything currently, but I think if you are interested in finding out about that, I would suggest that you contact Iona Novak. I might just sort of type her name into the chat, but they are definitely, New South Wales group are active in that area as far as trying to secure funding for stem cell trials.
Great, and I think there's time for one last question. Delivering perinatal stroke news to parents and counselling about prognosis can be challenging. How do you approach this?
Yeah, so I mean, my experience with that is that sometimes parents come with sort of misconceptions of what their child's outcome may be, and so they may have either been told or based on their own searching that they think that it's inevitable that their child will develop cerebral palsy. So often they're relieved when they come to the clinic, and I say to them that, well, actually there's only a 1/3 chance that your child will develop cerebral palsy, and also that there are ways that we can identify that early based on the general movements assessment. And so I think it's very important to address those key questions, because they want to know why, and at the moment we don't know why stroke occurs. There are a number of risk factors that are associated with perinatal stroke, but because it's a rare occurrence, there's no way you would be able to answer that in a conventional epidemiological cohort or case-controlled study. What's the child's development? Well, I think we do have information about cerebral palsy, and the general movements assessment is part of the standard approach by allied health professionals, so that you can tell them that your child will be assessed at 3 months. We will identify it as early as possible, and then we can get those early intervention strategies in place. Will it happen again? I mean, the counselling of that is that no, that it's highly. I mean, I 20 years of seeing patients in stroke clinic. I've never had a child that's never had a family where the child's had a recurrent event if there's no identifiable cause. So I think, the only exception that would be in a child who has congenital heart disease. Yes, there is a significant risk of recurrence, but if you do an echocardiogram, the child's not known to have congenital heart disease, then they're not going to have a recurrent event. And then future pregnancies, it's very important that in hemorrhagic stroke, for example, genetic testing is something that's important because there are some genetic disorders which affect connective tissue integrity, which can be associated with recurrent stroke. So there's the COL4A and 1 and 4A2 mutation. So now we have a child who presents with a hemorrhagic stroke, a newborn with a bleed, we do those tests as a matter of routine. So I think, things are changing, but how do you approach that? I think it's just approaching it with sensitivity and having, organisations such as the Stroke Foundation to support families and linking them up with other families. Those things are really critical to support those families.
Thanks, Mark. Some reassuring information there for families, I'm sure.
Marty and Mark, thank you so much. And Belinda as well. I appreciate you all joining us today. As Mark just mentioned, we've got a host of resources available for childhood stroke at the Stroke Foundation website, but you will all be forwarded those at the end of this webinar. If you jump on and register for your CPD certificate and complete the survey that's loaded onto your browser right now. Mark, testament to how interesting this has been today. Pretty much everyone has hung on right past the end time. We've gone a little bit over, but we really appreciate your time and your expertise today. And I think we should definitely carry on the conversation around perinatal stroke further on down the track.
Yep.
Be fantastic. Thank you, everyone. We're getting lots of thank yous through and a few more questions as well, which I'll direct to Mark. But appreciate everyone joining us, and we will be back with the next webinar in a few weeks. Thank you.
Thanks, Leah. Thanks, everyone. Bye.
Bye.